So we'll go through just systematically, no particular order. That's not necessarily how we do it in our clinical exam, but we'll just follow the order on the screen. So the Tinel's test, like I said, this was ulnar nerve hypersensitivity or irritability. I'm just going to have her in a relaxed position. There we go. And that allows me access to the nerve. And I'm just going to tap along the course of the ulnar nerve. And I'm, of course, looking for reproduction of kind of this symptoms along the fourth and fifth digit. We're just tapping like that. As I mentioned before, always key to do both sides because many people are sensitive on both. And so if you go immediately to the injured side, do that first. You know, oh my God, they're really, it must be ulnar nerve. And it's like, no, they're sensitive like that on both. So now let's have you lay flat on your back, your head right here. Good. And this is the ulnar nerve subluxation test. And you can do this in many, many positions. This isn't necessarily the best, but this is recorded in the literature quite frequently. So we put her in a 90-90 position, as you see here. I take my hand and put it in her hand, and I kind of extend the wrist and supinate the forearm, which puts a little bit of tension in the ulnar nerve. So then what I'm doing is I'm kind of bringing her forward like this, and I'm looking down right along the medial epicondyle. I don't know, Randy, if you can get in there good enough or whatever to see. I don't know that she has a, I'm not sensing that it's subluxing, but it would be in this position, usually in this range of motion. As I go through this mid-range, you'll just see it go blip, back and forth. And you usually don't want to necessarily, if it's irritable, you don't want to do it like 6 times, like, hey, look, I found it or whatever, because it is irritable and it can actually produce symptoms. But if it's going to come out, I'm in external rotation, as you see here. This is usually the position that'll make it go back and forth. All right? So ulnar nerve subluxation test. So go ahead and sit up facing me if you would. Scoot down to this edge, maybe. Or how, is it hard to get too close?
No, you're good.
Oh, good? Okay. So the ulnar collateral ligament, we know the anterior band is active in extension. So in this young woman's case, you can see she can extend or hyperextend her elbow. So I definitely don't want to test her in this position because there's a lot of bony congruity in that position. But instead, as I flex her about 15 to 20 degrees, and then I want to be somewhat cognizant of humeral rotation. So I don't want a lot of rotation in her humerus. I'm going to bring it up about 15 to 20 degrees. I'm going to use my thenar eminence to kind of block the radiocapitellar joint on the lateral side of her elbow. And then I'm just going to use this small little motion to open her elbow medially, and then relax and let it off. So you feel that opening and then closing, opening and closing. You feel that. One of the pitfalls of this test, if I'm too flexed, as I go to do this, you can see that's just wiggling, that's just moving her in internal external rotation with her humerus. That doesn't do anything. And if I'm all the way extended too far, there won't be hardly any motion at all because the elbow is too stable because of the bony congruity, as I was mentioning. So you can do it this way. Now, Dr. Conway, as we mentioned, does it, rather than in front of the body, does it on the lateral side, so almost in the coronal plane. Same hand position, same everything. It's just that in this position, you're putting the shoulder in more of a closed pack position, so the shoulder is going to be less likely to move. So it's just another way of doing the valgus stress test. We're looking for the amount of opening as well as the degree of provocation. Realize that if you have flexor pronator tendonitis or tendinosis, that many times this test will be positive with that as well because it's aggravating because the tendon is being elongated. You're putting a stress through the tendon. So just because it's sore there doesn't necessarily mean. If you have soreness in the absence of laxity, you would think maybe it's just a problem with the tendon. If you actually have soreness with laxity, that would be more indicative of an ulnar collateral ligament injury. So some of the other things we presented was just a good hands test, so you could ask the patient just to push the ulnar borders of their hands together, and again, looking for pain in that location. It doesn't measure laxity or anything like that. The milking sign, that's one for the posterior band of the ulnar collateral ligament. So if the individual isn't able to do it themselves, let's say they just can't reach across and whatnot, then I would just grab the thumb like this, caress the elbow, and then just give them a valgus stress in that position. And that would be, again, the milking sign. So the moving valgus test of O'Driscoll, I think I'll do the left side, Randy. That way you can see it better. So we just get any trauma in the shoulder? Mm-hmm. Okay. So get her into full abduction external rotation. They don't talk about forearm position, so I would typically, I've used a neutral position. I just put her in full external rotation. I give her a little bit of overpressure to give her that modest valgus load. I start her in 120 degrees of elbow flexion, and then I extend her to about -30, looking for that zone between 120 and 70 as being exquisitely painful and reproducing their throwing type pain, or that whatever that medial elbow pain is that brought them into your office. That's the O'Driscoll moving valgus test right there. All right. Next test is valgus extension overpressure test, and that's very similar to doing the valgus loading. And when we do the valgus stress test, unlike the valgus stress test, which is in 15 to 20 degrees of flexion, we actually start this with more flexion, do a valgus load through the elbow, and then extend them at the same time. So it's a little bit of a daunting test to the individual, but a little bit of a valgus load and extend them into full extension. We're again looking for pain, particularly in the posterior aspect for posterior osteophytes, but it can produce pain medially or compressive pain laterally. So we're just asking, where does that hurt you? And it didn't hurt you, right? So it shouldn't have any pain, but I would want to know where that hurts. So one more time, elbow flexion, valgus load, put her into full extension. So that's everything on page 1. Page 2, Vera stress test. What we would do is basically we can cross our hands. And so I'm blocking on the medial side, and I'm just going to do a Vera stress test in about 15 to 20 degrees again of elbow flexion. If you didn't want to actually move, you could actually do this, do your valgus stress test by blocking with your thenar eminence and using your hand on this side to then do the Vera stress test. But I like to have the biggest part of my hand blocking on the side that I'm doing the resistance. That's just personal preference. It doesn't have to be. But that would be the Vera stress test. Our radiocapitellar compression test, you actually put your hand in their hand, sort of like yesterday when we did the labral test for external rotation supination from Dr. Andrews. This, you put their hand in their hand, and you do wrist extension and radial deviation. And in doing that, we're actually loading the radiocapitellar joint here laterally. And I'll do this on both sides so you can see maybe on the video. And then all we do, I use the thenar eminence of my hand again on the radiocapitellar joint. I just scour by loading, keeping the load in extension and radial deviation. Then I just scour through pronation and supination and light elbow extension flexion. I scour the lateral aspect of the elbow, the radiocapitellar joint. So here's how it would look on this side: extension, radial deviation, just like that. So that's our radiocapitellar compression test. Our repeated elbow flexion test is just something that she does. She sits up, flexes her elbows all the way, has them supinated, and then wrists extended. And she would hold that test for a period of several minutes to see if it brings on any symptoms in her 4th and 5th digits. All right. And then the last one is just a provocation test, and we were discussing how it does make a difference in if you do it with the elbow flex. So if I'm going to do for the extensor carpi radialis brevis, I'm going to be over the 3rd metacarpal, have her extend that position. I palpate here and I actually resist that motion. It's just nothing more than a manual muscle test. But I'm seeing if it reproduces pain on the lateral epicondyle. If it doesn't, I'm then going to place her in full extension and retry to see if she has more pain in that extended position. So big difference, as we were talking about, between elbow flexion and elbow extension. Okay. And that's an overview of the special tests of the elbow.